Hi everyone, welcome to our webinar today. My name's Wendy, I'm with Career Cert. We've got an awesome team with us today from the UT Southwestern group, and we are talking to you about stroke-like symptoms. And we're going to be reviewing a 911 call. I'm very excited for this. So why don't I introduce you to our presenters today from the UT Southwestern team. The first presenter is Dr. Paul Rosenberger. He has over 30 years of EMS experience and 20 years of adult education instruction. He has performed ground and flight paramedic duties in leadership in town administration during his service. He also served as a faculty member and assistant program director for UT Southwestern, and currently Dr. Rosenberger is the associate director of the EMS Continuing Ed program at UT Southwestern and an adjunct faculty member for the Emergency Services Administration, BAAS program at the University of North Texas, Dallas. He is also the co-chair for the National EMS Education Standards Development Revision Team, so we're very happy to have Dr. Rosenberger with us. Our next panelist is Dr. Gil Salazar. He's an associate professor of emergency medicine at UT Southwestern. He serves as the medical director of EMS education and oversees both initial and continuing education of area EMS professionals. He is currently practicing clinically at Parkland Hospital Emergency Department, and Dr. Salazar is duly board certified in emergency medicine and EMS and serves as core faculty for the emergency medicine residency and the EMS fellowship programs at UT Southwestern Medical Center. He's the creator of campus emergency preparedness and survival training, and his main goal is to improve the quality of education and the management of natural and human-made disasters. And our last panelist, Ms. Virginia Smith, is a licensed paramedic for Cypress Creek EMS in Spring, Texas, which utilizes aggressive emergency protocols. She's working in the in-charge paramedic position in ambulance teams responding to 911 calls. Virginia received her bachelor's in biology from Texas A&M and her master's in biomedical sciences from University of the Incarnate Word School of Osteopathic Medicine. And very exciting that Virginia will be starting medical school this fall. So we're very happy to have this expert group of panelists here to talk you through our stroke-like symptoms. I'll turn the time over to them.
Well, good afternoon, everybody. Thank you so much once again to Career Cert for having us this month. We're super duper excited about bringing you this case. Couple of housekeeping notes. First, I would like to acknowledge Dr. Paul Rosenberger, whom I've known for a very long time, and he will be leaving us for greener pastures. Hopefully, he can join us at some point once he starts his new gig at National Registry. So, Paul, I'm remarkably and forever grateful for your friendship, your mentorship, and your kindness. And the world of EMS owes you a debt of gratitude for all the hard work that you've put in. Virginia, I'm very, very proud of you now that you're going to be going off to medical school. So very happy to have mentored you. And just like Paul, I hope this is not the last time that we get to play together. We're going to discuss a case today. I really like cases that are multidisciplinary in nature, beginning from the 911 call and then kind of taking you through what happens all the way at the other end of the spectrum at the hospital. I really believe there's a lot of learning, a lot of education, and a lot of lessons that can be gleaned from following that a patient through that continuum of care. And this is one of those calls that kind of caught my attention, and I would like to share it with you. So let's discuss it a little bit, and I'll tell you exactly, kind of almost verbatim, a lot about the things that came through. This came in as a 911 call for a 50-year-old woman with a history of bipolar disorder and some history of esophageal disease, who was at her workplace when bystanders noted she was noted to be freezing up. That is what was documented in the EPCR by the medics, and that's what the verbal report included. Bystanders reported the patient's face was drooping toward the right, and since the workplace had undergone some training as far as medical emergencies, they did the right thing and they called 911. The call goes out 5 minutes after symptom onset, which to me is really, really impressive for a workplace. And that's an aside, but we really should be pushing for community training and medical emergency. So kudos to that workplace for taking the initiative of taking care of that patient. I thought the medics did a phenomenal job of providing this report, and we then started kind of going through their assessment. They began to assess the patient, and this is what we find. The patient is hypertensive. There is no tachycardia, normal respiratory rates, good SpO2. The patient is afebrile. They checked blood sugar, which was a little bit low at around 58 milligrams per deciliter. They reported a medication profile that included the aripiprazole, which is Abilify. It's a medication used for things like depression, bipolar disorder, bupropion, the same type of deal. The trade name is Wellbutrin. And then the citalopram, which is selective serotonin receptor inhibitor used for depression, anxiety, that type of deal. The patient was not on any GI medications at the time, and they, of course, reported wisely there were no allergies. I pulled off the chart, kind of what was documented, and kind of recalling what the medics verbally reported about the patient, and some of the things that stuck out. They were very impressed with the patient's word finding difficulty. The word aphasia was not used. It was difficulty finding the words. They reported weakness of both extremities, not one favoring versus the other. There was no drift and no facial droop. The organization, the agency that was taking care of this patient uses a Cincinnati stroke scale, and I'm sure there are others here. And they wisely ascertained the last known normal by the time she was in the hospital was approximately 40 minutes. That included some transport time, etc. I'd like to pick on Virginia a little bit, and as we start diving into this case, Virginia, what is your process in your agency for taking care of patients like this with stroke-like symptoms?
Absolutely. Well, every patient that we see, we do a full primary assessment, which includes some sort of a stroke scale. If we're thinking stroke, which when the bystanders reported right-sided facial droop, even though we don't see it, we have to take their word for it and maybe go along that line as a possible differential diagnosis. We do a fast stroke scale, and then we go on with that and do a race stroke scale. And that's what we report en route to the hospital to give them kind of a number of how bad our clinical findings are. A lot of other people can do other forms of different stroke scales and can report that, but that's what we often use. And I'm lucky that I have a primary and a comprehensive stroke centers all in my district that are pretty close. And so when in doubt, I treat it like a stroke, even if I'm not sure it is, even if it might be something else. I'm looking at that BGL is a little bit low. There could be something else going on. Might as well go ahead and treat it like a stroke. I can't say for sure it's not. So we're going to go lights and sirens. We're going to go to the comprehensive stroke center and go ahead and call them en route and activate that code stroke.
Thank you. I think that's pretty traditional for an urban EMS system that's high functioning, and leveraging those resources at that level is superbly important. That's exactly, it mimics what was done with this specific patient. The medics went ahead and called that code stroke from the field as part of the clinical guideline and the processes established within the area. I would like to pick on our friends listening in today. Let's go ahead and launch the first poll, Paula. And I'd love to kind of hear what y'all's do, what's y'all's system do in this type of system. So how would you proceed from this patient? There's no wrong answer. I'm kind of curious to see, and then I want to see the results. Do we load the patient, the back of the box, and repeat a stroke scale and kind of reassess since the findings are kind of a little bit murky? Some agencies go in and do kind of a CSTAT and kind of further assessment and assessing for a large vessel occlusion or LVO stroke. Is that part of your organization's clinical guidelines? Do you take this patient to a comprehensive stroke center based on what you have in your clinical suspicion, or do you transport this patient to the closest facility or primary stroke center, depending on what your resource availability is, what resources you leverage? So I'm really curious to see. So please kind of participate in the poll and let us know what you think.
Hey, Dr. Salazar.
Yes, sir.
As they're answering this poll, I kind of want to pack a few things here. You know, in that previous slide, the medics clearly documented and completed a Cincinnati stroke scale. And so they had documentation on the facial droop, the arm drift, and this abnormal speech. And when you look at the American Heart content, you're going to see that they say that if any single item is present during this assessment, that's a 72% indication of a stroke. And if 3 items are present, it indicates that there's a 90% chance of a stroke involvement here. One of the things that's really not very sophisticated in the Cincinnati scale that I think we need to deliver today is that the Cincinnati scale does not pick up posterior strokes. And as you know, the vessels that primarily feed the posterior aspect of the brain are the vertebrals. And so the Cincinnati scale really is just picking up the assessment of the middle cerebral artery, which of course is a common site for strokes. And so I think really we see that this Cincinnati scale was completed by the team of paramedics, but really they didn't do any type of assessment because of a posterior stroke because of the Cincinnati scale. You know, another common scale is the Los Angeles pre-hospital stroke scale. And that one adds a few more components to it. And so it adds age. So it asks, you know, is the patient greater than 45 years old? In this case, this patient is, she was 50. It inquires about seizures. You know, could this be something that would present somewhat like a stroke? How long have the symptoms been present? You know, less than 24 hours. Is the patient wheelchair bound or bedridden? And as we've been hitting all over here, the glucose in this patient was 58. And the Los Angeles scale wants, you know, to assess the sugar to see if it's between 60 and 400. And then it goes on and does typical things like facial symmetry, hand grip, and arm strength.
Well, and it's screening tools for stroke and EMS. You know, these are pretty well validated screening tools and very easy to apply. I would really like to reiterate and point out something very important. You said it's posterior circulation. Strokes can affect your cerebellum, and you can have a stroke scale that's absolutely stone cold normal. And so as you kind of take some of this information today, kind of keep in mind and that the stroke scales that you use are pretty well validated tools, and I'm glad that you're applying the knowledge today. It sounds like we're about 39% of you would take the patient to your primary stroke center or closest. 23% to a comprehensive. Some of you would be assessing for an LVO, and then others want to go ahead and load them up and repeat a stroke scale as the picture is still a little bit murky. So let's move on to the next slide, Paula, and let's see the progression of things. As we mentioned earlier, this specific organization went ahead and activated a code stroke from the field, and an entire hospital-based process is launched when that happens, and that includes within our organization the patient going directly to the scanner. We bypass pretty much everything, just straight shot to the scanner, where the entire clinical team gets a page for a code stroke, and everybody meets the patient in the scanner themselves. And the team, it's a really pretty comprehensive team, includes emergency medicine, neurology, clinical pharmacists, our nursing colleagues, radiology, etc. A secondary assessment is done on the patient at this time. And these are the things documented by the clinicians. And this includes the word aphasia. So at this point, it looks like the patient is having significant difficulty speaking, phonating, answering questions. They also document word finding difficulty. So could those two things be one and the same? Really difficult to say. They do document right-sided weakness compared to the left, and so we use a strength scale. Kind of 5 is kind of full strength, and 4 out of 5 it means very slight weakness, but it is documented and it's significant. We're going to discuss the National Institute of Health kind of scale here shortly, the NIHSS. Which was a 5 in the emergency department. We're going to discuss that shortly, and we'd like to share a little bit of that knowledge with you in the spirit of being innovative and teaching you something new today. But it's a 5. The top is 42, and Virginia is going to go through some of these shortly. Because of the ongoing symptoms, because the patient is kind of within that window for thrombolytics, the decision is made at that point to go ahead and order the TPA. And for those in the audience who may not be familiar with it, you may be at the EMT level. Perhaps a thrombolytic is basically a clot buster, and we don't take that decision very, very lightly. And if there is indeed an infarct being caused by an embolus and a stroke, this clot buster can really go a long way in restoring perfusion. And there are many parameters that have to be met before the decision is made to push the TPA, including the patient's blood pressure, medical problems, use of anticoagulants, etc. But the decision is made in real time to go ahead and order the TPA, and the team gets going.
Dr.
Next slide.
Yes, what is pushing y'all to order the TPA? Is that the scale of the 5? Is that her aphasia? What makes y'all decide that at this point?
The NIHSS 5 in this patient tells us there is indeed an objective neurological deficit. Subjective is very tough. We try to make a very objective decision because this is not a benign medication. It can cause bleeding in the brain, bleeding in the body. It can have some very detrimental effects. The benefits outweigh the risks, but the risks are real and they're present. So if you give me a patient with ongoing neurological symptoms that fits the criteria in terms of time of last known well, and you give me an NIHSS of 5, I guarantee you all of these things are what contribute to giving the patient the decision, putting an IV in them and pushing TPA.
And hey, Virginia, just so you know, this score of 5 is an indication of a milder type stroke. These patients can be scored as high as 42, but a 0 is a normal score, a 42 is a horrible score. And so somebody who fits in the category of 1 to 5 is having a mild stroke. Somebody who is said to have a severe stroke is somewhere between 15 and 24, and anything greater than 25 would be considered severe. So this person is scoring on the low end of the stroke scale. But again, as Dr. Salazar has indicated, there's objective findings that there is a neurological deficit.
100%. Next slide, Paula, please. One of the things that we need to do before we push TPA is do a computed tomography, a CT or CAT scan of the brain to make sure that these stroke-like symptoms are not being caused by bleeding. And that is really the true reason why we do such a fast CT on these individuals. And just to orient our friends who may not be familiar with kind of what a CT looks like, it's a cross-section of the brain. It's essentially going to be going in this direction. And in this situation, we have the patient's head away from us on a table. And on your left-hand side is the patient's right. On your right-hand side is the patient's left. And we're looking for symmetry there. All the structures on the left and on the right should look exactly the same. You see the ventricles or those kind of darker areas, kind of butterfly toward the middle there. And we don't see any areas that look different from the other side, anything that looks like a big collection of blood. And it's a very, very fast study. We kind of look at it in real time. And if the CAT scan is unremarkable, then that kind of checks one of our boxes to consider giving the patient TPA. And so I just wanted to orient you guys on that one. Next, please.
All right. So what we've got here is the Cincinnati triage or stroke triage assessment tool, or the CSTAT. And this is a stroke scale that really is looking for large vessel occlusions. And the reason why that's significant is it's useful for us routing these patients from a primary to a comprehensive stroke facility. And the way you use this tool is that any patient who scores a 2 or higher is suspicious of having an LVO. And so you can kind of see the scoring here. If you start looking at the gaze of the patient, particularly the horizontal gaze here, if it's abnormal in any way, they would automatically score 2 points. And then you come down to the next row here, and you ask the patient to answer their age and the month, I'm sorry, and then you ask them to follow a command of some sort, open or close your eyes or open or close your hands. If they can't do both of those, then they get another point, and then you go on and you assess the arms and see what you get there. And this is much like the Cincinnati scale. So if they can't do that, then they get another point there. So they could receive as many as 4 points. But again, to be suspicious of an LVO, all you need is 2 points. And so again, every protocol is different. And so if they score less than 2, if the patient has the aphasia, there are some cases where those patients would be routed to a comprehensive stroke facility. And this is just one stroke assessment for LVOs. There are others. I mean, there is, Virginia, you mentioned, I believe, RACE, which is the Rapid Arterial Occlusion Evaluation. And that one looks at facial palsy, arm and leg motor responses, head gaze and deviation, aphasia, and agnosia, which is limb recognition. And there are others like BFAST, which assesses, balance, such as dizziness, eyes, is there loss of vision or abnormal vision. The F is the face, the arms, the speech, and the timing of it. And there's probably about 6 or 8 different scales out there that can be used. Today, we're just covering the CSTAT because that's the one that we're most familiar with and the ones that we use. I totally respect Dr. Salazar when he has to choose which stroke scale that we're going to use to assess an LVO.
Absolutely. And when I call in route, they ask for either a CSAT or a RACE, and they'll take whatever I give them. And I think they use on the RACE score a cutoff of 4 as a predictor for the LVO. But whoever answers the phone knows both and goes off of what I give them.
And the reason we're showing you some of these to our learners watching us today is a lot of the things that are done pre-hospital to help us assess patients and screen them for stroke, to assess for large vessel occlusion stroke, and for other types of stroke, including a posterior circulation stroke. They're very, very similar in nature to what we are going to do in the hospital. And so I wanted to share with you the next slide. That now that we know what tools are out there, Virginia, tell us a little bit about the NIHSS scale. And now I'm going to tell you this: you don't have to memorize this. This is not something that I'm going to be quizzing you on. I just wanted to let you know kind of what items kind of go into doing a formal NIHSS in the decision to take care of a patient with a stroke and pushing thrombolytics, or even doing an endovascular type of procedure is not taken lightly. Virginia?
Absolutely. So this is a common tool that most ER physicians or neurological physicians use. Often with my patients, as soon as we walk in the door, the ER physician's waiting and he'll do it right there. Sometimes it's in CT, sometimes it's after CT, but it's helpful to kind of know what he's doing. It's similar to a lot of the other stroke skills. It's just a little bit more parts to it. And it gives everyone a number to quantify the clinical findings, and that way they can communicate across the board the severity of what's going on. So it's on a scale from 0 to 42. 42 is the most severe, 0 is the least severe. If there's a 0, there's no stroke symptoms at this time. It doesn't mean that they had a stroke or maybe it resolved, or maybe they're currently having a stroke just with no symptoms, but there's no clinical findings that can be quantifiable at this time. And as the numbers rise, the stroke is more severe, and that can be communicated across all boards. It also can be communicated at different points in time. So if maybe the score was a 5 when they entered and it gets worse to 15 later, that's helpful to know. As well as, yeah. And so the first is just like levels of consciousness. And it's, is the patient conscious? Can they answer questions? Are they aware of where they are? And can they obey commands? The second is the best gaze. And that's when you see the physician holding up their finger and ask the patient to track. Some people might do that in the field. Others just wait to do that in the ER. The third is the visual fields. And so there's 4 sections. And the physicians make sure that the patient can see all 4 sections. If half of their visual field is lost, that's a significant clinical finding. And so if they can't see anything on the right side, that's important to know. The fourth is facial palsy, and that's what we typically do when we ask the patient to smile or raise the eyebrows. And each of these different sections has 0, 1, 2 order of severity. The fifth is the arms, and that's when we see the physician ask the patient to raise the arms, hold it for 10 seconds, see if one side drops or one side drifts. The sixth is the legs, same thing there. The seventh is limb ataxia, and that's when we see the physician ask the patient to touch his finger and then touch their nose, touch his finger, their nose, in different sections. Often they also ask the patient to take their heel and rub it against their other leg just to see if the movement is smooth and accurate, or if it's kind of chopped up and kind of like someone with Parkinson's, where it's not smooth. The eighth is sensory. The physician will touch both sides, see if it's equal on both sides, and if the patient's feeling significant loss or able to feel it at all. The ninth is best language. Sometimes we'll see pictures. The physician will hold up cards, ask the patient to name like a cactus or a hammock, or they'll have a scene going on and the patient has to describe what's going on. Sometimes the ER physician doesn't do this, and they do this either later or they have another way to assess this. The 10th is dysarthria, and that's slurred speech. So aphasia is having problems with like the cognitive understanding and the mental words getting out. Dysarthria is you're able to understand, you're able to comprehend, but the muscles to move your mouth and to form the speech are not working. And that's where we get the typical slurred speech. And the 11th is extinction and inattention. That's often when we ask the patient to close their eyes, the physician will touch the arm and say, hey, which arm did I touch? Whose arm is this? And see if the patient's aware if that's his arm. They'll add up the scores of all of that. And again, it's on a scale from 0 to 42, and that does the severity of the stroke symptoms at this point.
Thank you, Virginia. An amazing question came in through the chat, very related to this. And the question is, should EMS professionals be reporting aphasia, given that there are several types of aphasia, including things like Wernicke's, encephalopathy, and aphasia? And the answer, in my humble opinion, is yes. And let me tell you why. I think for many, many years, we consider strokes to be kind of a very focused, kind of narrow type of deal with a very narrow scope of symptoms. You know, they had to have a speech deficit and some extremity weakness and some pronator drift, etc. Very, very classic. What we've found over the years as we push the boundaries of science is that strokes can be absolutely humbling in terms of the spectrum of symptoms. And, you know, over the years, patients with findings as small as a sensory, like numbness of the face without any deficit whatsoever. These are some of the patients that wind up at your door and who actually have a stroke. Aphasia is one of those findings, and aphasia is one of those symptoms that you should be very, very careful with, because the parts of the brain that are controlled, that controlled speech and would result in aphasia are generally affected by large vessel occlusion strokes. And so aphasia is a very significant finding. So I would rather hear from an EMS professional giving me that report on the front end. That way I can keep that in my differential rather than neglecting it. So you have my full blessing to always be innovative, to push the boundaries, coordinate the care with the receiving facilities carefully, and report all of these symptoms. And aphasia is definitely one of them. And here's the NIHSS scale that tells you, yep, it's a significant finding and we're going to ask about it. So I would love for our EMS professionals out there to recognize it and report it to me. So thank you, Virginia. I wanted to point out one last deal in regards to the NIHSS. Like many other things go into it, like your ability to spatially put things together. What is a scene looking like? Can you put all these things together? Those difficulty doing those things could be a sign of a stroke. Next slide, please.
And before we move on, I just want to recenter us that our patient was scored as a 5. And again, that's on the low end, indicating perhaps maybe a mild stroke. And so again, anything greater than 25 is very severe. This scale is super duper robust. It's very sophisticated. It's very systematic. And when you go out on the internet and look for this, you're going to see that there's courses out there that you can enroll in. In fact, American Heart has a course that you can enroll in to learn how to do this properly. And so, this is a lot of information for an EMR or an EMT, perhaps even maybe an AMT or paramedic. But it's a great way to assess our patients. And the more knowledgeable we can be in assessment of strokes, the fewer we're going to miss. And so I would encourage you to look into this further. Even though this is typically done in the hospital, it is certainly going to enhance your skills as a clinician when you assess a patient who has a stroke.
Absolutely. Thank you, Paul. Next slide, please, Paula. Paul, you and I, let's go ahead and discuss the update. Paul, go for it, and we'll have a little back and forth.
So as this patient, we've already discussed that this patient, they have decided that this person was having a stroke, and the signs and symptoms they were seeing were consistent with that, and they made the decision to administer the TPA. So as they're reassessing the patient, they notice that the head is turned to the left, which is kind of a unique and kind of a unique distortion, which we'll talk about here in just a second here. And the patient answers the question slowly with effort, but she is able to pronounce or use some words correctly and others incorrectly. And now all of a sudden the extremities, the strength in the extremities are intact, and the patient is able to follow commands that are repeatedly prompted. And so now we're like, oh, something's different here, and we want to continue to do our assessments here.
Dr. Rosenberger, it seems like there's a lot of decisions being made. Who's making the decision at this point? Is it the ER physician? Is it the neurologist? At what point does it switch over? And who's typically running the case at this point?
Virginia, I'll take that one. There is such a thing in medicine and many other disciplines, and in a vacuum of leadership. When you have something this complex with multiple personalities, sometimes not an established leader helping make decisions, having a broad overview of things can look a little bit murky. So I think from your question, it sounds like you're wondering, is there a primary person making some of these decisions? Having been in this situation myself many years and having been on scene for many years, I can tell you that a high functioning system should always have one person leading the charge. As complex and as difficult as this scene in the hospital was, There was actually a always one person who was overseeing things, and as we're gonna find out, it was this person overseeing things that started saying, "Wow, things are looking just a little bit weird right now." So yes, definitely for our friends out there, a vacuum of leadership can get us in trouble in the out of hospital arena. It can also happen in the hospital arena, and I urge you to always push the boundaries of leadership and leadership development for your crews to avoid any issues in decision making, multiple personalities trying to kind of take the lead on things. Next slide, please.
All right. Yeah, when you go back and consider the history that we saw on the front end, this patient was taking quite a few medications, and the history did not include a history of hypertension or atrial fib. Those things would be risk factors for a stroke. But anyways, we're going to launch into this next poll.
Let's see what our friends out there think. We just discussed leadership and a leadership vacuum, which wasn't present in this situation, but things started becoming a little more murky. Now your patient is talking with a little bit of effort. There's no deficit there. So what would you do if you were in our shoes, or you were on scene and still taking care of this patient? Do you continue current management as it is? Go ahead and call it a code stroke. Patient had stroke-like symptoms. You made the decision. Now they're getting better. Still go ahead and do it, or you say, hold on a second, something is not looking quite right. Perhaps not a stroke, maybe, or some aspects of this are consistent with a stroke. Some others aren't, but I'll probably still go ahead and proceed, or I don't know. And it is okay to not know. Sometimes in medicine, eating a bit of piece of humble pie is just as important as knowing the right thing to do. And this is a very complex case. So let's see what you guys feel while we're talking a little bit about kind of what's going on in the room. And guys, by this point, as we mentioned, there are a ton of people. The medications are drawn. The pharmacists come out of their office with the medication ready. All the pumps and infusers are ready to go. So let's see what our friends here want to do, Paula. Let's start getting the poll results.
Okay.
Let's see what our friends think.
I'm ready to do the spoiler alert here, but I'm holding back till we get a few more answers on the poll here. But yeah, I guess
I'm going to pick on you just for a second. And I think it's important to mention that we see these doctors as these gods of medicine. They know everything, and okay, it's out of our hands. Y'all know everything. Here you go. And I know I've gotten tunnel vision and gone down one line with the patient and kind of had to reassess and figure out it was something else. Or once I got to the hospital, it was something else. And it's important to note that doctors do the same thing.
Medicine. Go ahead, Paul. Go ahead.
I'm going to take us back to the initial slide with the assessment. The sugar was 58, and that's very suspicious. That's very, very low there. And this patient was taking some antipsychotics, some antidepressants, and medications like that. And again, those are things that we just got to consider when we do these differential diagnoses. Look at the whole picture. Because perhaps some of those things could help explain why the patient's presenting as they are.
Thank you, Paul. Yeah, I think this reflects kind of what I would expect, as we are go-getters in EMS, and when we make a decision, perfectly okay to keep it going. Others I would expect have a little bit of pause with some of this. It's a little bit murky. We're still having a little bit of fun, and I am so proud of the 19% that said I really don't know. Virginia, to your point, medicine is a series of colors in black and white, but the true professionals, the best in the business, learn to love and thrive in that gray area. And sometimes not being able to know what's going on is living in the gray area. So it is perfectly okay to do that. So kudos for admitting we don't know. So let's see what's happening here, guys. Next slide, please, Paula.
So I'm gonna spoil it all. The choice to give the thrombolytics was discontinued, and the patient was not given the TPA.
My colleague, I'm just going to go ahead and name her Dr. Hale. She's been a phenomenal colleague, tremendously smart for many, many years. Renowned toxicologist, was the one overseeing the care of this patient. And as things began to just look a little less murky or more murky, that's when a true professional, a true expert kind of comes to the table and says, you know what, something is not consistent with a stroke here, and the risk of giving the patient the thrombolytic all of a sudden goes a lot higher than the benefits. As many of you may expect, the diagnosis was not an acute stroke. My friend and colleague said that this could be, based on the patient's medical history and medication profile, a dystonic reaction. The dystonic reactions are a very, very interesting phenomenon to me. It is, by definition, a movement disorder. It is caused by certain medications, particularly antipsychotics. We call them neuroleptics, and also some antidepressants. And certainly the patient is on both the aripiprazole and the citalopram. The antidepressants certainly can do something like this. And really the hallmark of these dystonic reactions are going to be kind of very slow, rhythmic, involuntary movements on the face, on the extremities, particularly the upper extremities, and also even the larynx in terms of phonation. Patients may have difficulty with getting some words out. The positive thing is that the effects are globally reversible, and they can occur really immediately after starting a medication in the next few days, or patients can be on these medications for a long period of time and develop these dystonic reactions. One of the scarier things about dystonic reactions, even though this doesn't happen frequently, it is known that certain antiemetics, including ondansetron or Zofran, as the trade name, can cause dystonic reactions. So to my friend and colleague who had the presence of mind to maintain leadership, taking care of this patient and making a very tough decision that was very unpopular at the time, kudos, because she made sure recognize what the issue was. Next slide, please.
And just so we're clear, Dr. Salazar, as the paramedic in the field, I would still continue to call the code stroke if I saw the signs and symptoms that we saw early on in this case.
Very interesting. Virginia, what would you do?
I think I would too. Even if we don't think it's a stroke or there's something that just is off or murky, we can't say it's not for sure a stroke. Even the physicians in the ER and neurology was involved at this point thought it was a stroke. That's not something that we can rule out in the field. And so might as well treat it like it is, but take note of everything else that's different and murky. Communicate that on the phone, communicate that to the physician when you get there, and yeah, get more people and the doctors involved.
Amazing.
And I think that the key point there is the treatment time is critical in a stroke patient. And so even if we see a patient with this kind of history and we see these kind of signs and symptoms, we should go ahead and assume the worst and treat this patient as if they were a stroke, and then let the physicians and the CAT scanner and all the lab work sort this out for us.
Thank you. Virginia, as we go on to the next slide, have you seen this before? What is your take on dystonic reactions?
We have a frequent flyer that is on a lot of these same medications, and I see him probably once a shift, if not twice a shift. And at times he has this rhythmic tongue movement, not all the time, but at times there's this dystonic reaction, and it's well known that he gets this, and it's kind of like that character in Harry Potter that has his tongue kind of sticking out. It looks exactly like that, but it just goes to show that these dystonic reactions can come across with different presentations and can kind of just look weird at times.
Tell me a little bit about the patient, kind of the mouth, any findings in the mouth, tongue?
He just kind of messes. I mean, it's kind of hard to describe, but it's just kind of this rhythmic tongue movement. It's kind of his tongue sticks out a little bit and then goes back in, and it's not super fast, and he just kind of continues to do this at a regular interval all the way to the hospital.
If you didn't know this patient well or have not run on him before, could somebody conceivably on the street or even a medic say the patient may be having a stroke?
This presentation is not as stroke-like as the presentation that in our case study here, but they could, and they would not be wrong to consider that in the differential diagnosis and activate it if that's what they thought.
How do you treat it, Virginia?
So thankfully, dystonic reactions are a lot easier to treat than strokes. It's diphenhydramine, 1 mg per kg, up to 50 mgs in adults and pediatrics. The onset of treatment is really rapid. Within 30 minutes, you should start seeing results. And if you're not, then you can maybe consider perhaps it's something else. Perhaps it's just taking a little bit longer for this patient, but definitely communicate that you gave this treatment when you get to the ED.
The patient, as you might expect, maybe somnolent after 50 milligrams, especially in adults, a pretty large dose. It is perfectly okay to give it in children as well. And this can occur in kids, and you may see it. And can kids have strokes? Absolutely, they can, particularly kiddos with things like sickle cell disease. And that's why I teach, even at the initial level, a medication history, and knowing, at the very least, having a familiarity with the classes of medications the patients are taking can be absolutely management changing. Paul, you and I had discussed a little about the pathophysiology of dystonic reaction. From an education standpoint, Paul, how deeply should we be teaching this at the initial level about dystonic reactions and the patho for it?
I can tell you the current education standards do not address dystonic reactions directly. There is certainly an emphasis to enhance a paramedic's knowledge on chronic medications, as you just mentioned, because it is very helpful in the assessment and the diagnosis of patients. You know, early on in this case, you know, when you look at the medications that this patient took, the Abilify, the Wellbutrin, and the Celox, you can tell quickly that this patient didn't have like a history of atrial fib. You know, one of the things we're not going to discuss today is, you know, the role of anticoagulants in stroke care. But, you know, the fact that those medications were missing would probably be some type of clue that the patient doesn't have AFib. And there were no antihypertensive medications as well. So there's probably not a history for hypertension. And just knowing these medications and these classes, as you mentioned just a minute ago, will give a paramedic a little bit of clue as to the previous conditions that the patients had. You know, just ask him straight out, do you have hypertension? Do you have any abnormal heartbeats or heart failure or anything like that? And then those medications are kind of a secondary confirmation as to what a patient may or may not be taking and the history that they may or may not have. And so to answer your question, is dystonic reactions directly addressed in the education standards? The answer is no. But having some idea of what these chronic meds are and their profiles is really going to be helpful and make a better clinician in the field.
The medications, these antipsychotics and, you know, those antiemetics, what they wind up doing is they call something called extrapyramidal effects in the brain. And these extrapyramidal effects are they're a big spectrum. And in certain patient populations, that spectrum really involves some very, very concerning, very stroke-like symptoms, like in this patient. And so, you know, that begs a question for me, both for initial and continuing EMS education. Maybe perhaps we should start considering teaching our young men or our young women, EMS professionals out there, not just signs, not just symptoms, but risk factor profiles. You mentioned, what if this patient did have hypertension? What if they had atrial fibrillation? What if they had diabetes? Could a stroke be a more likely diagnosis? Since this patient didn't have really any of those risk factors, I, as a clinician, I'm gonna think about it twice before I commit to the diagnosis of a stroke. The second point that I wanted to bring up specifically about this case is something called anchoring. Virginia, you and I have discussed this in the past, and anchoring refers to kind of latching on to a diagnosis and clinging on to it for dear life, forgetting that there are potentially many other causes for what you're seeing. Virginia, do you think that there was any anchoring here where we clinging on to the stroke? You know, this was called from the field and we were committed to it, we were pushing forward. Were we anchoring here, or did Dr. Hale kind of save the day at the end of the day?
There might have been a little anchoring going on, which is okay. The stroke is the scariest thing. It's the time you need to get it within the certain time frame to be able to treat. It has horrible lasting effects if it's not treated properly. And so I understand the big scary diagnosis is kind of what everyone was thinking and everyone was acting towards. I think it's smart that there were those reassessments, and that's just the importance of reassessment in the field and reassessment in the hospital, and multiple smart brains involved in looking at these patients with new eyes instead of just going off of what the first clinician told them. So I think there might have been just a little bit, but I can understand why.
As we're beginning to wrap up, I wanted to give the opportunity to our panel to ask a live question. We tried that last time with some good success. If you'd like to ask a question live, please put it in the chat and let Paula know that you would like to ask a live question, and put your question on there, and Paula can shoot it to us. And if we think we can answer your question, we'll unmute you and you can ask a question. Paul, we try our very best to prevent dystonic reactions in patients. You asked me when we were prepping for this webinar, are there treatments or prevention strategies to mitigate this risk? And one of the medications that is used is something called benztropine or cogentin, which is a medication used to, an anticholinergic used to curb and prevent these symptoms. So that is yet another potential clue on patients like this. If the patient is on benztropine or cogentin, should think about dystonic reaction very, very highly. I'm gonna take a question here. This one is not live. This is an outstanding question. Dyslipidemia or hyperlipidemia, high cholesterol. Should we be including that in our sampler history? That's one of the main questions that we had. Should we be including it?
I think that's something that often patients tell me, and at the time, sometimes I roll right past it. But if they know that that's in their history, it's important to include and important to pass on that information.
Very cool. I agree. I think as we were discussing earlier, and we can go to the next slide, Paula, as we were discussing, a risk factor profile based type of history can be very telling. So yes, in patients with stroke-like symptoms or myocardial infarction symptoms, I am going to be asking these risk factor questions, not just as a physician. I would love to see it in an EMS. Let's get to our last slide. I am very big into utilizing our time efficiently when we are asking questions. And forever and ever, Paul, you and I have been teaching our students and our graduate medics that L is for last oral intake. And I'll make the argument that in some situations it can be useful, but in the overwhelming majority of situations, a last oral intake is not going to change your management. But there are a couple of L's that I really, really like, and the L in sample history, last known well. Paul, tell us a little bit about last known well, and kind of we've used last known normal for many years. What are your takes on this new concept of last known well?
Well, what's funny is if you go to the 2020 guidelines from the ACLS textbook, which was released late in the fall of 2020, they continue to use this term normal. And so one of the terms that we really want to emphasize is last known well. And we believe that the term well is just plain better terminology because, you know, what we really want to know is what is the baseline for the patient and how different is the event that we're seeing today from that typical baseline. Now, is there baseline abnormalities that are not seen, you know, in previous days and today, or in this case here in the last 40 minutes, the baseline is abnormal for this particular patient. And so it's a better descriptor of, you know, the baseline as opposed to normal, because I don't really know what normal is. I mean, perhaps normal is this person's up and runs a half marathon, you know, every 3 months, or maybe they're more bedridden or something. But normal is very different from one patient to the next. And so that term well more is based on what is the baseline for this given patient.
Thank you, Paul. The last known well when it comes to bedtime has been one of the most controversial pieces of discussion. You know, is it what if the patient gets up in the middle of the night and they don't have a deficit, then they go to bed? So what is considered the last known well then? What about what is really bedtime for patients? Is that the patient's actual last known sleep, or did they wake up in between, take a nap, and they were acting well, they were normal? And then really what I would push for us to move toward is really the last meaningful witness well before bedtime. That should be our last known well. I said goodnight to my husband, my wife, completely normal at 9:58 p.m. and shut off my phone. That should be the last known well. We got 2 minutes left. I'm going to answer the last question here in the chat, and it's a very good question. Should we be thinking about antihypertensives in EMS for patients with stroke-like symptoms? And my answer to is if one of the biggest pieces in modern EMS is going to be the integration of EMS into the whole healthcare family. And if you have a dedicated medical director, a hospital system that is very supportive, and you're integrating EMS care into the operational aspects of patient care, then I think that there is room for high functioning agencies to develop clinical protocols to use antihypertensives. And I want well-trained medics. I want destination capabilities ironed out. I want good parameters, and I want to know that the patient is a good candidate for TPA. That's really one of the big reasons in patients with intracranial hemorrhage, etc. I want to delineate that very well. So thank you for your very thoughtful question. My simple answer is a yes, with the right preparation. I would like to thank Dr. Rosenberger, soon to be Dr. Smith. I would like to thank Wendy. I would like to thank Paula. Welcome to the team, and thanks to all of you for coming today. We look forward to serving you in the future, and if we can be of any assistance, please let us know. Again, thank you so much and have a great afternoon.
Thanks, Dr. Salazar. We really appreciate your preparation and this important topic that you guys discussed today. We would love to have you guys continue the conversation with us at CareerCert. We have a lot of additional webinars that are available on demand, put on by the UT Southwestern team, as well as some various other webinars pertinent to EMS. So go ahead and head over to careercert.com for more free webinars and free resources to help you best protect yourself and your fellow providers. If you want to earn free CAPC accredited CE hours for attending this webinar today, please complete the assessment that will be emailed to you within the next 48 hours. It will be sent to the email that you registered for the webinar with. So you can expect it there within the next 48 hours from a Career Cert employee. Once you complete that assessment, then we will automatically report your CE hours to CAPC. Thank you again for connecting with us today, and thank you for your sacrifice to make our communities safer places. Take care, everyone.
Good job, everybody. Good job, Virginia. Good job, Paul. We'll see you guys on the back end.
All right, thank you much.
Thank you.